Colon cancer is the second leading cause of cancer in the United States. But why is a cancer that is so preventable so deadly? Well, to talk about that and the importance of getting colon screenings, we are here at GI Associates in Stevens Point, Wisconsin. My name is Raquel Lamel, and I'm joined here with two doctors from the practice, Dr. Vance Hartke and Dr. Keaton Jones. Doctors, thank you for being here today.
Thanks for having us.
Thank you.
And we're talking about colon cancer here today. It's the second leading cause of cancer in the United States. Why? Because it's so preventable.
Well, colon cancer, there's about 150,000 cases in the past year diagnosed, split evenly amongst men and women. But the question is, how do we prevent that cancer if it is truly preventable? Well, every cancer, and colon cancer is no exception to this, starts off as a cluster of precancerous cells that slowly grow over time. And we know from studies is that these precancerous clusters of cells, also known as polyps, will typically take 10 to 15 years for them to grow into a colon mass that can invade the wall and spread to the rest of your body. So the goal of a colonoscopy is to be able to place a flexible camera into your colon and evaluate your colon for these clusters of cells and to remove them at the same time. We can diagnose colon cancers while doing that. And in some cases, when it's an early stage cancer, we can remove it at the time of the colonoscopy to prevent you from ever having a full-blown colon surgery with an ostomy bag and sometimes even requiring chemotherapy. That is an added benefit of the colonoscopy, but realistically, if colonoscopies are employed at accurate intervals and at the right times, depending on your risk, ideally we can prevent the cancer from ever occurring by finding that polyp, that precancerous cluster of cells before it ever progresses to a colon cancer.
Now you speak about the right time. When is the right time to get that colonoscopy? The age is actually younger than people think.
It used to be 50 when I first started my medical training. In the past several years, the age has actually come down to 45 based on data that's come out over the past 30 years. And what we know about colon cancer is that every year it's increasing its incidence by about 1% to 2% in the population. And not only that, the early onset colon cancers, those people who are diagnosed with colon cancer before the age of 55, has actually doubled over the past 30 years. So overall, it's increasing at any age bracket, but it's significantly increasing in the younger population. So starting colon cancer screening at 50 with a colonoscopy by a highly trained gastroenterologist is important. But starting at 45, 5 years prior to 50, we might be able to accurately find some more of these polyps and remove them before they become colon cancer, as opposed to waiting to 50 like we used to do.
You talk about finding polyps, but if you're just the layperson, right, how do you know? What are their symptoms? Are there symptoms that you would notice?
Great question. So with colon polyps, no. Very, very rarely will you ever have symptoms from colon polyps. But as the cancer progresses, you can develop symptoms, and symptoms being like rectal bleeding, where there's blood in your stool, as well as a change in the caliber of your stool, where your stool might be a little bit thinner than it used to be. Some patients describe it as like pencil-like bowel movements. Additionally, unintentional weight loss is a concerning symptom, as well as symptoms of anemia. And what does that mean? Those symptoms are like fatigue, lightheadedness, shortness of breath. Those would all be alarm symptoms that you should definitely talk to a gastroenterologist about. And these stool and blood-based tests that can tell you if you, at a reasonably well rate, if you have colon cancer, but we know that they fail at telling you if you have colon polyps. So they'll never be able to tell you if you have these precancerous lesions that are growing inside you until they become a colon cancer. That's when these non-invasive tests are technically useful, but in our field, we want to prevent that cancer from ever coming on, and the only way to accurately do that is by getting a colonoscopy.
If we want people to do this earlier at 45, is there any demographic of people? Does it discriminate by age, gender, race, or is it across the board, anybody?
So it does not discriminate, but there are risks that might actually indicate that you should get your colonoscopy at an earlier age. Things that can affect that are like a family history of colon cancer, as well as a personal history of inflammatory bowel disease, and certain genetic syndromes can also be at play that might also increase your risk, and you should get a colonoscopy sooner and talk to a gastroenterologist.
We tend to look at family history to make that decision. If you have a first-degree family member that had colon cancer or who had an advanced polyp, so a polyp that was almost a cancer, and if they had that before age 60, we consider that you're probably high risk. So in those patients, we tell them we want them to come in at age 40. Now, if your first-degree family member, say your brother had colon cancer at age 45, then we actually say, well, you should come in 10 years earlier than the age that your first degree relative was diagnosed. So if your brother was 45, we want you in at 35.
And that probably goes with what you said, where you said 10 to 15 years for that polyp to develop, right?
Exactly. That's why you want to start it at an earlier age if you have a higher risk of forming these polyps at an earlier age.
Let's talk about then, we're seeing the word early a lot. So that early age, or that diagnosing early, why is that so important? What difference can that make?
Well, diagnosing early in terms of preventing the cancer, of course, that's the important thing, preventing the cancer from ever occurring. But, also if you're detecting the cancer at an early age, that has benefit as well. So you think about cancers across the board. In addition to colon cancer, there's 4 stages. For colon cancer, we talk about stage 1, 2, 3, and 4. 1 being that colon cancer is confined to the lining of the colon. That cancer can be actually endoscopically resected at the time of a colonoscopy, with survival rates exceeding 90% at 5 years, just with a colonoscopy without any other high-risk intervention.
We try to get them at stage 1. It's not always stage 1 when we end up seeing these cases. So the further the stage is, as Dr. Vance was kind of alluding to, the treatments become more aggressive and the survival becomes worse. So when we start talking about stage 2 cancers, those are cancers that are growing into the bowel. They typically require surgery, still with good outcomes. If they're going through the bowel and they've gotten into any of the lymph nodes around the colon, now your survival is significantly worse. So you may only see about 70% survival at 5 years instead of over 90%. And those cancers tend to require chemotherapy and surgery. And then when you unfortunately find some cases that have already progressed to stage 4, it's mostly palliative treatments.
I just had a patient last year who I found a very large high-risk polyp with some high-risk features within the polyp, and with ulcers, and it was oozing a little bit of blood at the time. We removed it with some advanced techniques, and I had him see a surgeon afterwards as well as an oncologist. And they actually felt that there was no other therapy needed at that time, because we actually cured the cancer when we first removed that polyp, when we found a small focus of cancer within the polyp. Had we waited additional time, had he waited until 50 instead of 45, that cancer likely would have progressed to stage 4, where it would have spread throughout the rest of his body.
What is a colonoscopy? What is all a part of that procedure?
So colonoscopy involves kind of using a flexible camera, as Dr. Vance mentioned early on. Flexible camera to go up around the colon, all the way to the beginning of the colon, kind of where your appendix is. If you have a good exam, many times you'll go into the end of the small intestine, and then you kind of work your way backward with this camera, and you're looking for any polyps that may be growing on the lining of the colon. Lining of your colon, just imagine, kind of looks like the inside of your cheek. That's what the tissue looks like. You're just looking for these abnormal growths of cells. And then while you're doing the procedure, we can use different techniques to remove those growths. For a colonoscopy, you do have to do a bowel clean out. So we've tried to make that process easier. Actually, it was one of the only good things that came out of the pandemic, was that we made the prep easier. It was harder to get the big jugs of salt water that people used to have to do in the past when they would moan about how bad it tasted and how much volume it was. Now we've shifted towards, we tend to tell people, buy a couple of Gatorades, buy your favorite flavor, just don't buy red. And then we tell them to mix some Miralax, which is just kind of a gentle laxative, in those bottles of Gatorade or Powerade. And that's what you're going to drink. You're going to drink that the evening before. It's going to flush your system out. And then you come into, say our center here, Stevens Point. You're probably with us for a total of 90 minutes. The whole process for doing the colonoscopy, once you get there, where you get to talk to staff, talk to an anesthesia provider. Not all of our patients even use anesthesia. You don't need to have anesthesia with the colonoscopy, but typically people do. And you take about a 25 minute nap. You wake up, feel pretty refreshed 20 minutes later, talk to you about your results, and then that's it. You're on your way.
This procedure is really only as good as the doctor who's performing it, right?
If you're having your procedure with a skilled gastroenterologist, the risks of having any complications, hurting the colon, hurting the spleen attached to the colon, incredibly rare. But that's one of the fears that you hear from patients, that, I had a family member that had some kind of injury to their colon when they had their procedure. And a lot of times if you ask them about that, it's, well, they had it done by maybe somebody who doesn't do it for a living, doesn't do it all the time. So we try to tell patients, hey, this is all we do. We're not good at any other procedures. I can't take your appendix out. Can't take your gallbladder out. But we can do these colonoscopies, and we can do them very effectively, very safely.
And just to piggyback off what Dr. Jones just mentioned is that, talking about us being the specialists for the colon as well as your entire GI tract, there are other doctors out there who do these procedures as well. Obviously, they didn't get the extensive training we did at doing these procedures. But the way I equate it to patients when I talk to them in the clinic is like, why should I get it with you versus, another doctor out in the community? Well, would you get brain surgery by a general surgeon or would you go to a neurosurgeon? Well, if you're going to get a colon procedure, you should probably go to a gastroenterologist.
Yeah, precisely. And we say as good, well, that means safe, one thing, and then it means effective at preventing colon cancer or detecting colon cancer if somebody has it. You want to go to a provider who is really good at finding those precancerous polyps. And there is a wide differential as far as how good certain endoscopists are. We tend to look at quality of endoscopy by what percentage of polyps you're taking out. Now, in general, we think that the average 45-year-old that comes in and has their first colonoscopy, there's a 50 to 60% chance that that person should have polyps removed at the time of that procedure. And you may see patients who have seen other providers in the community, and they may be only taking out polyps in 15% of their cases. So you're talking about a significant difference, 60% versus 15%. We know from really big landmark studies, if you're 1% better than the person next to you, that equates to about 3% more colon cancer being detected. So 3% less colon cancers long-term, 5% less mortality long-term for just 1% better. So when you're talking about 15% versus 60%, you can imagine the difference in colon cancer prevention, mortality prevention, when you see somebody who does this and does it effectively.
The national average, the acceptable rate for what we call polyp detection rate or adenoma detection rate, it used to be 25%. It's actually increasing to 35% over the past year. What we found at GI Associates, we keep track of our numbers, how many polyps we detect, and as a group, we're greater than 50%. So we're twice as good as the national average at finding these polyps.
You mentioned GI Associates is 50% better than the national average with screening, but there's a lot of other screening options out there. So how does that number compare with some of those others as far as tracking?
Yeah, so I think that points out one of the big distinctions, right? So those 50 to 60% of cases that we're finding polyps, we're taking them out at the same time. We're not leaving those polyps in place. Whereas a lot of the other non-invasive tests and some of the newer tests that are coming out in the next year or two, they're leaving those polyps in place until they progress to an advanced enough stage that they show up on your stool test or on potentially even blood tests in the future.
Talking about these screenings, I think everybody has seen the talking box on TV, mail in a sample. That's one form of testing. How is that different than traditional colonoscopy?
A Cologuard test is going to look for signs of microscopic blood, which is kind of a surrogate marker sometimes for large polyps or cancers. It's also going to look for changes in DNA that can be shed in the cells that come off of the lining of the colon. A lot of the cells in the lining of your colon come out in your stool, and they can be assessed in a laboratory to see if you have any abnormal DNA markers, which can be seen sometimes in these advanced polyps or cancers. You many times are going to catch the cancers, but more rarely are you going to catch anything that's not cancerous. We actually had a patient just last week who had a negative Cologuard 18 months ago and came in with a pretty advanced cancer. So there is a subset of patients who will do a Cologuard that will come back negative, and they may actually have colon cancer. It mostly is identifying cancers, probably is only catching about 40% of advanced polyps. So about 60% of advanced polyps aren't going to be detected on a Cologuard. When a Cologuard does come back positive, patients will always need a colonoscopy anyways. So whenever somebody does have a positive Cologuard, now they have to shift over into having a colonoscopy to go and evaluate it further. Whereas if they had come in and had a colonoscopy initially, they would have gone through the same process regardless and had the ability to potentially take out high-risk polyps if you had them at that time. So you have a better ability to prevent cancers if you're going to go in and take a look and remove those precancerous cells like Dr. Vance was saying. People
out there may have heard of other screenings, right? Where we're kind of talking about one, but are there other screenings and how do those relate to colonoscopies? What are the other options?
The three big ones that you're seeing done are colonoscopies, Cologuard tests, and then a test called FIT, fecal immunochemical test. So FIT looks for that microscopic blood like the Cologuard does, but it doesn't look for any DNA changes. FIT is actually used a lot in big organizations like Kaiser Permanente or Veterans Affairs Hospital System. There's another stool-based test that you may start to hear about. It's called ColoSense. It looks for some of the similar things as a Cologuard Plus. Data is pretty similar for the Cologuard Plus. It's going to catch about 94% of cancers. It's probably only going to catch 40 to 50% of very advanced polyps, which could soon turn into cancers. The kind of newest test on the block is going to be blood-based tests. We're going to start hearing a lot about blood-based tests for colon cancer screening. 2 different tests that are coming out. One's called Freenome, one's called Shield. They're probably going to catch about 80% of cancers. So they're going to miss about 20% of cancers. They're going to catch probably only about 60% of those stage 1 cancers, those early cancers that you could cure endoscopically. So they're going to miss 40%, at least on the data that we have so far. And then when you start to think about high-risk polyps before they've turned into cancers, this is where blood-based tests are really lacking, because they're only going to catch about 10 to 15% of those advanced polyps.
Who might be a good fit for some of these alternative screening options? Is this a good option for anybody?
Yeah, I think, there's a place for all of these tests, the stool-based tests or blood-based tests. I will say that colonoscopy is always going to be considered first line. If you have a patient who is just incredibly concerned about having a procedure or doing the prep or having sedation, there is value in doing something rather than doing nothing. Because, if you have a positive test, then maybe that conversation changes and you're able to convince them, hey, you have a positive test, this is what that could mean. We really do need to do a colonoscopy. So I think that in patients who are really hesitant, we're not trying to force anyone to do anything they're not comfortable with. In general, a lot of these non-invasive tests, they're just from our experience, we know they're going to miss a lot of precancerous lesions. So we try to explain that to them. If you do one of these tests and it comes back negative, there's still a good chance that you're going to have precancerous polyps inside of your colon. And we're going to hope that if you're able to come back at 1 year, 2 year, 3 years and get another test done, maybe we're going to catch it, but maybe we won't. So I compare it to telling a patient, there aren't a lot of other precancerous conditions in the body that we leave in place, that we don't get rid of before it turns into a cancer. You go see your skin provider when you have a worrisome mole and you get it treated. You don't come back a year later and recheck it when it turns into a cancer. We don't do pap smears saying, well, you've got some precancerous cells, come back in a year when you have cervical cancer. So as long as patients understand that there's a risk when you do a non-invasive test that you may have precancerous condition that could have been treated. If they understand that, then that's okay. Everybody has the ability to make their own decisions, and we'll support them, and we'll do whatever we can to ensure that they stay up to date with whatever screening they want to do.
Oftentimes when patients have their concerns, and after telling them all this, and they might be reluctant, like, oh, I understand, that a colonoscopy is a better test to prevent me from getting cancer in the long term, but also maybe the short term prevent some disease from happening. But on top of that, it's like they still have their hesitation, and then they'll be like, well, what would you do, Dr. Vance? And I'll be like, well, honestly, me and every other gastroenterologist in the country would be getting a colonoscopy. Nobody would put themselves through the ambiguity of one of these stool blood-based tests, knowing that there's a high probability that I could still have a precancerous polyp that's growing and growing and growing with time until, finally that stool test becomes positive and the horse is out of the barn. And then unfortunately I might need chemotherapy, surgical resection, ostomy bag, and God forbid I might even die from a disease that could have been prevented had I just got a colonoscopy.
Thank you guys for being here today. And thank you to all of you for joining us. Please do yourself a favor and schedule a colonoscopy today. Finding the polyps early, it can truly be the difference between catching cancer before it even develops. You can truly only do this by receiving a colonoscopy at a doctor's office. So please make sure to find a quality doctor like GI Associates to perform the procedure. It's the best form of detection and early intervention. So reach out to GI Associates. The number is at the bottom of the screen. And remember, one night of prep is worth a cancer-free future. Schedule your colonoscopy today.